Good morning. This is Dr. Wilshire, your fertility insider. Today's a Wednesday. That means it's a surgery day. We've just started driving into work and we're getting ready to go operate. As you can see, surgery days start early at dark 100, as Dr. Penny would have said. Surgery days are a big deal. We prepare for them. It's almost like a track meet or some kind of sporting event. There's preparation well in advance. We try to get our mind and our body ready to get into the zone so we can do our best work. My preparation is involved getting a good night's sleep, not too much coffee, not too little coffee. I haven't lifted weights in a couple days, so my arms are fresh. And I've started to review the cases in my mind that we have scheduled for today. We have a block on Wednesdays, which means we have a morning that we're supposed to fill. And in fact, we fill it week after week, year after year, because unfortunately in this field, women need surgery. It's the only way we can fix the many things that can go wrong. I reviewed the cases yesterday, so they're kind of in my head, and I'm turning them around, thinking about them. Our first case is a young woman that has a recurrence of pain. Pelvic pain is a big problem. And this is a woman in whom we've done surgery in the past. We found severe endometriosis. We fixed it as best we could, but by all signs and symptoms, it appears to have come back. It's been about maybe 8 years for this woman, which is not uncommon. This woman, like most women who come to see us, want to have her parts preserved. We have a different mindset in this field. We're here to save things. We don't want to take out an ovary or take out a uterus or take out a tube unless we absolutely have to. And that can be tricky. This first woman is going to have extensive scar tissue and probably invasive endometriosis. We're going to have to work carefully and systematically and try to restore normal anatomy. Restoring normal anatomy is a maxim or a rule of virtually all surgeons, and reproductive surgery is no different. Our second surgery is on a woman who also has some pain that appears to be coming from her right ovary. Her right ovary has a large cystic mass in it, and an ultrasound, it has a somewhat distinctive appearance, which makes me think it's something called a mature teratoma. They're also called dermoids. We call them hairballs. What happens in a dermoid is one of the eggs in the ovary decides to get into its little head that it wants to make a person. Unfortunately, an egg only has half the genetic material to make a person, but it does the best it can. And what it does is it creates some of the various tissues of the body. And it appears that eggs have a lot of genes and a lot of desire to make the skin part of the body. That's why they call it a dermoid, or skin-like structure. These masses form hair and oil, sometimes teeth, sometimes cartilage and bone, other bizarre things, but usually it's hair and oil, and we call them dermoids. Our goal today is to take the dermoid out of the ovary and save the rest of the ovary. We are really keen on saving ovaries. If we took out the whole ovary, we'd cure the problem, but then this woman would lose half of her eggs, which is not desirable. We want every egg we can get. And when we take the dermoid out, we want to save every egg in that ovary as possible. So we have tricks for doing this. They're generally very successful. We generally do these surgeries through tiny little holes. We call this minimally invasive surgery, also called laparoscopy. It used to be called pelviscopy. You can even call it endoscopy if you wanted to, but it's generally called a laparoscopy. We almost always combine that with a look in the uterus called a hysteroscopy. That way we can check out the entire reproductive system and get the whole thing tuned up and ready to go. Kind of like a NASCAR pit stop. You want to go out and win the race with everything adjusted and fixed. I call this surgery the bumper-to-bumper surgery, in fact. Patients get a kick out of that, but everybody understands what we're talking about when we do that. So, we're about halfway into work. I'm going to start drinking my protein shake. Get in safely. And we'll continue this video in the operating room.